If you want to figure out the most likely cause of your back and buttock pain for free without needing an x-ray, an MRI, or getting painful injections, then stick around because in this video, I'm going to walk you through a complete diagnostic flowchart to help you figure out why you hurt. My name is Dr. Charlie Johnson, physical therapist, and this diagnostic flowchart is created from knowledge and experience that places me in the top 0.5% of PTs worldwide. If you're watching this video, I'm going to assume you have back and buttock pain. You may also have some thigh pain that remains above the level of the knee. If you have both sided symptoms, that's okay. We'll talk about that very briefly, but this is going to be the most common presentation. And so what could be causing it? It could be many things. First things first, we want to roll up big, ugly, scary things. They're not very common, but they can occur, so I want to make sure you don't miss them. So we're going to give you everything you need to rule out with a high degree of confidence if something like a cancer, a fracture, an infection, or a blood supply problem, peripheral arterial disease, PAD, is causing the back, butt, and leg pain that you're experiencing. Then we're going to move on to more common causes of pain in this area, which would be disc herniations. Then facet joint problems in your lower back, degenerative joint disease, arthritis, lumbar spinal stenosis. Then, believe it or not, your brain and or mind can make a bit of a mistake. You feel very real physical pain in your back, butt, or leg, but it's not caused by physical damage to the body. Instead, your brain becomes sensitized and makes a bit of a mistake. Funky stuff here, again, not made up. We'll talk about how you can figure out if that's the cause of your symptoms, especially if you've tried everything and nothing has worked. Now, when you're trying to diagnose and or figure out the cause of pain in these areas, it's also useful to rule out causes so you can get closer to what something is or closer to the truth. In this case, if you have pain in these regions, I'll tell you right off the bat that you most likely, almost without a doubt, do not have myofascial pain due to a muscle or fascia issue. You don't have sciatica, you don't have piriformis syndrome, and you don't have SI joint pain, and we'll talk about why and how I feel so confident saying that. Okay, so fork in the road. Body can cause pain in this area. Brain can make a bit of a mistake and also cause very real pain in these areas. Let's talk about the body first. So we want to rule out big, ugly, scary things. How do we do that? You can see my resource here in case you care to check it out. Cancer, 0.6% chance that when presenting with back, butt, and leg pain, that cancer is the cause of it. So about 6 out of 1,000 people. Not very common, but worth not missing. And this is the cluster of findings that we use from this article to screen for cancer. So age greater than 50 years old, a previous history of cancer. It's italicized because a previous history of cancer is the biggest predictor of cancer as the cause of your back or butt pain. Unexplained weight loss, meaning you're losing weight but you're not trying to, and failure to respond to natural treatment. And this is useful because cancer causing your back, butt, or leg pain can be ruled out with 100% certainty if you, the person in pain, is less than 50, does not experience or exhibit unexplained weight loss, does not have a history of cancer, and is responding to natural treatment. And that being said, what if you do have one or multiple of these things? If you do have a previous history of cancer alone and you check that box, and or you check 3 out of 4 of these things, we call these red flags, then typically we would recommend you get an x-ray and some basic blood work. So ESR is erythrocyte sedimentation rate to kind of look for markers of inflammation in the blood. That's how we rule out cancer from a clinical perspective without an x-ray or MRI to begin with. Fracture, again, not very common. Here you can see the resource that I've cited here, and this is the cluster of findings we're screening for. Are you a female? Are you greater than 70 years old? Did you note that the back pain, buttock pain, leg pain started as a result of physical trauma? Maybe you were in a car accident, you fell, something like that. Do you have a history of corticosteroid use, maybe for some other health condition you've taken for some prolonged period of time? If 3 out of 4 of these boxes are checked off, we may want to refer out for medical imaging to rule out a fracture as the cause of your symptoms. Infection, again, not very common, but we can see bone infections, which you can experience back, butt, and kind of pelvic pain, whereby the symptoms start, but it's associated with, say, a fever greater than 100.4 degrees Fahrenheit. Body aches, chills, just generally not feeling well, nausea, fatigue, all that stuff. If so, you may want to consider infection. Blood supply issue. We're going to dive deep a little bit more on this because I've seen this actually recently multiple times. So peripheral arterial disease, here's what you need to know. This is actually pretty commonly a both-sided presentation. Not always, it could just be one-sided back, butt, and leg pain, and it could actually go all the way down the legs into the calves, but it could also present like this, and this is, again, more common. Both-sided symptoms, and you would describe this generally as cramping, weakness, heaviness while walking in the back, the thighs, the legs, that is consistent and consistently relieved with rest. Generally, this occurs in people who are a bit older, greater than 50, and folks who have, some different things which affect maybe their cardiovascular health. So smoking, high blood pressure, diabetes, high cholesterol, things like that. The symptoms are exertional, not positional. I'm going to dive deep on this in a moment. Basically, symptoms are related to how hard your heart works, not the position of your spine, which would point us towards maybe more of a spinal stenosis problem. And if you have an arterial problem, then it's not a mechanical problem with the muscles or the bones, the joints, or something like that. So you won't have any clear, consistent, yucky movements, meaning I could take you through a movement exam, maybe one like this, where you go through all these motions of your back, and you're like, hey, maybe I feel something, but you know what? It's not clear, it's not consistent, and it's really not a problem. So no yucky motions is common, which tells us it's not a problem with the discs, the joints, or anything mechanical within that muscle, bone, joint kind of nervous system. And here's the gist. So you can see on the left here that you have kind of healthy blood flow. So you have a heart, and then you have the aorta, which is an artery, away. Artery takes blood away from the heart, pumps it to different areas of the body. And you can see here that everything is green. There's no blockages or anything. You can see here I've done my best to kind of draw a little blockage or narrowing, we call the stenosis, of the aorta in this case, and maybe of some of the iliac arteries. And so you have good blood flow, and then maybe there's a clot, a chicken fat clot we call it, and or just some type of narrowing or plaque in this area, which is preventing full blood supply to the legs as they work. Now let's go back to this. Exertional, not positional. What do I mean by that? So let me show you something here. In this example that you can see, this person is walking, and their spine is in this upright position. The heart is having to work because as you're walking, your blood is having to be pumped to the legs because your legs need blood flow and oxygen to continue to walk. But what happens in this picture? This person, their spine is still in the same position. There's no change in their back position from here to here, but their heart is no longer having to work as much because their legs are not calling for as much blood supply and oxygen because they've stopped walking. They're simply standing, albeit in the same position. If stopping to rest in standing reduces your symptoms, then this points to a peripheral arterial problem. If stopping to rest in standing does not reduce your symptoms, then this points towards more of a lumbar spinal stenosis problem. A problem with the position of the spine, not with how hard and or how not so hard the heart is working. Now, in this case, let's just say that you are walking, your heart has to pump because your body and your legs need the blood flow, it needs to function. Your spine is in this position, and then all of a sudden you keep walking, so you're not, in this case, changing at all the effort required of the heart, but you change the position of your spine, you bend forward. And you say, you know what, bending forward does not reduce my symptoms. Peripheral arterial disease, I wouldn't expect it to because we're talking about the arteries, not a problem in the spine. But if bending forward reduces your symptoms, despite the same type of load or effort on the heart, then we start to say, could this be lumbar spinal stenosis? Very interesting. So peripheral arterial disease, I just wanted to give you an example here of a woman I chatted with. She came to me, she had no yucky motion, she had symptoms in both buttocks, back of the thighs, I think even down to her calves, and they felt heavy and crampy, just like I described. So I sent her out because I felt that it wasn't a fit to really help her mechanically with the problem she was dealing with. And she went to a vascular doctor, and they found that she had reduced blood flow. And she said, I'm so glad I joined the process and the program that I've created. I work with people all around the world with these problems because we really cued her into this. And, she found out exactly what she had. She went through many different doctors, and they found out she has this aorto-iliac. So aortic stenosis or narrowing, and iliac, another artery in the body, stenosis or narrowing, occlusive narrowing disease, all right? So they're going to clean it out, they're going to give her a stent, and that should improve the circulation in her legs, such as she has enough blood supply for her legs to work and she can walk again, all right? Walking was her big issue. Now, lumbar spinal stenosis. So let's just say you're walking, you bend forward and you say, yep, that feels better. Chances are high you have some type of spinal stenosis. Here's the resource I used to come up with the cluster I'm about to share. Age greater than 48. Leg pain greater than back pain. Oftentimes people with spinal stenosis have very little back pain, but they have significant butt and or leg pain, specifically when they're standing and walking. This is called neurogenic claudication. We'll get to that in a second. Basically compression of the nerve roots when you're in that extended position whereby the nerves are a little bit cramped and pinched off, if you will, for lack of better terms, and you reduce blood supply to them, and therefore you get symptoms. This is very important. relief with sitting, bending, and walking bent forward. So if you walk uphill and all of a sudden you say, wow, that feels much better, or when you're walking through the store, you get symptoms and you lean forward on a shopping cart, we call this a shopping cart sign, then that may indicate that you have spinal stenosis. And symptoms are more common in both legs. It could just be one leg. Before I get into that, let's talk about neurogenic claudication. This idea of leg pain that's worse with standing and walking, but maybe goes away when you're bending forward or sitting. So again, that's kind of a lack of blood supply to the nerves in your lower spine, which is causing you to feel symptoms. But now we want to prove it. So a lot of times physicians will ask what we call lead-in questions, whereby you'll go to them and they'll say, so it hurts when you stand and walk, right? And it goes away when you sit, right? And at the end of the day, this is a bad question because a lot of people will just say, yep, but prove it. They don't take you through a movement test. So an up tall test, let's do it. So here's what I want you to do. I want you to stand on up and I want you to walk, and I want you to walk bent forward. And if you're bent forward, this technically opens up or gaps the spaces in the spines where the nerves travel, thereby reducing the pressure on the nerves, and it should alleviate your symptoms. And if you walk up tall, and when I say up tall, really try to force yourself to walk up tall. Really try to pull your hips underneath. Well, this should make you worse. But we often find that people habitually bend forward like this when they're walking. And they think they're walking up tall, but they're actually walking bent forward. And what happens is when you're tilted slightly forward when you're walking, you're actually really stressing out the muscles in the back of the spine, which is the cause of pain in many cases, not the stenosis. And so then if you stand up tall, you take the tension off the muscles, reducing the strain, improving blood supply and oxygen to the lower back muscles, and really you're pinching off, or you should be pinching off the nerves in lower spine if you have spinal stenosis. But if that feels better when you're up tall and upright, then you do not have lumbar spinal stenosis. If there's no difference, you probably don't have spinal stenosis either because it should make it worse. It could be brain. Get to that in a second. And if you say, ouch, Charlie, when I go like this, from here to this, and I really put my hips underneath me, that makes my leg symptoms worse. Then in this case, you likely do confirm that you in fact may have lumbar spinal stenosis. Okay? Now, it is possible you could have lumbar spinal stenosis symptoms caused by a sensitive central nervous system. Believe it or not, the brain can create any very real physical sensation. It can mimic spinal stenosis as well as disc problems and many other things. We'll talk about that at the end of this video. You can see here, there's a woman named Pearl. She had spinal stenosis symptoms that kept her from walking, kept her from running. She would actually squat down in the middle of the store because that's the only thing rounding her spine. Sounds like spinal stenosis, right? Not really. That would take her symptoms away. There were some inconsistencies there, right? Her brain is super smart. Since joining the program, I've run half a marathon and resumed playing soccer. She doesn't use Motrins. And I taught her how to recognize the cause of her symptoms and what she needed to do such that she could solve them. Okay, so she got back to full speed despite being told and actually showing on her images that she had spinal stenosis. So it's not a life sentence there. You can often solve these problems. Okay, now symptoms in both legs. There could be many causes. It could be due to what we call bilateral both-sided foraminal stenosis. So you have spaces in the spine where the nerves come out either side. And in this case, the central canal might be fine, where the spinal cord is, but the lateral recess or foramen, the holes where the nerves exit, might be pinched off, and that causes issues here and symptoms down both sides. It could be actually due to not a foramen or hole problem on the sides of the spine, but a central spinal canal issue, whereby some of the ligaments become thickened and you actually reduce the space where the spinal cord travels and the lower portion of the spinal cord travels, and you get symptoms in both legs. This could be due to degeneration, generally in older folks, or sometimes in younger folks you'll have a congenitally, meaning from birth, narrowed spinal canal, which can cause this. And then finally, believe it or not, I just want to share this because a lot of people don't consider this. You can have narrowing of the spinal canal as well as these other places due to disc herniation. So when a lot of people hear spinal stenosis, they think, oh, it's just for old people or for older people, but not always. And so if spinal stenosis is caused by a disc issue, then oftentimes you'll see folks are younger than 50 years old. They have little to no back pain, but they primarily have butt and leg pain. Their legs are on fire. Unloading or lying down feels best because you're decompressing the spine. It may actually feel better to sit or recline because, again, you're unloading the nerves. It often feels worse to be standing or walking. It sounds like traditional spinal stenosis, maybe due to degeneration, but this can actually be caused by a disc problem. And yet it seems so contrary to the traditional way that people are told disc problems show up. Well, disc herniations cause pain when you're sitting and when you're bending. But you're telling me that I could have a disc herniation that could feel better with sitting and bending? Absolutely. And this is why it's important to not treat the diagnosis or the picture per se, but to treat you as a person and to start to figure out what makes you feel better and what makes you feel worse instead. So disc problems can often make you feel worse when standing or walking. Oftentimes you'll see a very yucky back bend and you'll actually feel better with a disc problem bending forward. And oftentimes it's caused by some lifting or bending injury, all right, that really causes a massive disc issue and causes a problem while you're loaded or while you're upright on your feet. And you can see here, contrary again to popular belief, an MRI showing that this person is bending backwards. And when you're bending backwards, that's good for disc problems, right? But this actually increases in some cases the size of disc bulges, whereby when you bend forward, you could actually be reducing the disc bulge, right? So this is not a one-size-fits-all type of approach where if you have a disc problem, you should be bending backwards constantly. You can see here that the holes or the spaces for Raymond in the spine where the nerves exit can actually become further narrowed by bending backwards. And if you have a disc herniation already taking up space in that region, then you may be making it worse by doing lots of back bends. You may actually make it better by bending forward. This is why it's important to work with somebody who can help you figure out your pain pattern and what you're going to respond best to. All right, so there you have it. Wow, it all started with the possibility of peripheral arterial disease, and then we branched into both-sided symptoms. So kind of a good transition here. Now let's talk about some more common things. All right, so if you have lower back pain, buttock pain above the level of the knee, I can tell you right off the bat, there's roughly, based off the evidence here, a 41-ish% probability you have a disc problem causing it, 31-ish% chance that you have a joint problem causing it, and then you can see SI joint and nerve problems go down from there. Now, like I said, when you're trying to figure out what something is, it's useful to know what it is not. So let's rule these things out. It is very unlikely you have a myofascial muscle fascia problem causing the pain in your back, butt, or leg. It's just not as common as most people are led to believe. We don't have the evidence to support it. In fact, this idea of muscle knots, tender points, trigger points may not even exist based off the recent research. And it kind of makes sense. What allows your muscles to be tender? Well, it's not the muscle itself. The muscle itself is simply a piece of steak. But what plugs into it? What plugs into it are wires, nerves. And so now what we believe to be the cause of tenderness within the muscle is due to a sensitive nervous system. So if you irritate, let's just say the L5 nerve in your spine, well, the L5 nerve plugs in and gives function and feeling to the muscles of your buttock, your glutes, the outer hip, the hamstrings, even some of the calf muscles. And so what we see is if you irritate an L5 nerve at the spine or somewhere along its path, you'll all of a sudden be tender in your butt. You'll have trigger points in your hamstrings and your calves. And you can poke and push and pull on these things all you want, but until you fix the sensitivity of the system, the nervous system, the tender points in your muscles won't go away and they'll just keep coming back. All right, so we believe that they are due to what we call neurogenic inflammation, nervous system sensitivity, not the muscles themselves. All right, so that's gone. Now, chances are if you have pain just in the back butt and maybe in the back of the thigh a little bit, that you probably don't have sciatica. And the reason I say that is sciatica is generally something that is felt below the level of the knee into the foot in a very narrow band, maybe 2 to 3 inches in diameter. It is not described as kind of achy, dull, kind of diffuse. Oh, it's just kind of in this area, hard to localize. It's very electric-like, numb, tingling, stuff like that. That would be more consistent with sciatica. So again, if you have symptoms above the level of the knee, we're going to say there's a much lower certainty that you have sciatica. We can kind of rule that out. All right. Piriformis syndrome, not the cause. Why? Back problems cause pain in the back, and they cause downstream pain. So pain in the butt and pain even down into the hamstring, maybe even down to the calf, but we're talking about above the level of the knee here. Piriformis syndrome, you can see in red here, does not cause upstream pain. So upstream problems, back problems, disc problems, joint problems, things like that, can cause downstream pain, but problems downstream, the piriformis in this case, do not cause referred pain upstream. So back problems can cause referred pain downstream, can cause you to feel pain in the piriformis area, the SI joint issue, the hamstring, all that stuff. But a downstream problem, the piriformis, for example, does not cause you to feel referred pain upstream in the lower back. All right, so not piriformis syndrome. And an SI joint problem, again, pretty darn low because it generally does not cause pain above the level of the belt line. Buttock pain is the primary complaint here. All right, so let's talk about disc and facet joint problems and tease this out. So if you present with symptoms that are central whereby symptoms kind of span across the level of the belt line. It crosses from the right to the left or the left to the right, and it spans across that area, and you've got stuff into the butt and or the back of the thigh, then this is a different presentation than if you just have one-sided symptoms that do not cross the midline of the spine. So which do you have? Let's talk about the probably more probable presentation for folks. So central back pain just above the belt line, spans from right to left in this area. This increases the probability drastically, just given the location of symptoms, to it being a disc problem, and reduces the probability of other things significantly. Now, if it's a disc problem and not something else, such as the mind, we should be able to move in certain ways and recreate our symptoms, because when we move certain ways, we can stress out the discs and the joints and things in the spine. So what I'm going to ask you to do is to perform a simple self-movement test, just some back bends here. So stand on up, feet shoulder width apart, hands on hips, and I want you to bend straight backwards. And the intent of this test is just to see, number one, how far can you go? And is it yucky or is it not? Does it reproduce your symptoms? Now what I want you to do is what we call a rotation extension test. So go ahead and twist your trunk completely to the left and bend straight backwards, testing the back left corner of things here. Then go ahead, twist completely to the right and bend straight backwards. Then you have a couple things that might happen here. Either it's going to be pain-free, in which case it still might be a disc problem, but maybe we didn't test out or tease out enough motions to really highlight the disc issue, or it could be painful. And most folks here watching this will experience pain if it is a disc problem while bending backwards in one of these three or all these three directions. Okay, so most likely a disc problem if painful. And then we can go to, well, what kind of disc problem? We get even more specific. So is it a large disc herniation, extrusion, sequestration? Probably not, because these things often present with symptoms below the level of the knee into the foot and cause sciatica just because of the sheer size of them. Now, what's more likely is a one-sided disc protrusion or herniation, a little bit more mild and or moderate. And some of the symptoms associated, if you just want to check these boxes to be sure, with disc issues are that you're generally a little bit younger, less than 50 years old. Symptoms are often central or one-sided along the belt line. They may shift right to left a little bit. Oftentimes there is trouble straightening or standing up after you've been seated for a while. Pain is often worse first thing in the morning because disc pressure is highest in the morning. Again, it's often worse with sitting, driving, bending, lifting, coughing, sneezing. If you cough or sneeze, it increases pressure within the spine, so it often causes disc pain to sort of be highlighted there. Sitting, driving, bending, they all have a common theme, bending forward, but I did talk about earlier that if you have a larger disc problem and or one that is more broad base, it can actually cause the opposite presentation where you feel better sitting. So just take this with a grain of salt, all right? Pain is often better with these types of smaller disc herniations while walking, standing, or even lying down. And typically in the history in the story, there's this roller coaster of back pain. So if you're watching this, are you one of those people who have back pain, back went out on you, then it gets better, and then the back goes out on you again, and then you get better, and then the back goes out on you again, and now you have maybe some butt and leg pain where before maybe it was just in the back. All right, so oftentimes it gets worse the more the back goes out on you. If you have a right-sided disc bulge, if you are going to be shifted, it's pretty much a telltale classic sign of a disc problem. You pretty much don't need to look at anything else, but not always, so it's not super common that folks will be shifted, but they will almost always, not always, but almost always be shifted away from the side of the bulge. In this case, right-sided issue would cause left lateral shift, left-sided issue would cause a right lateral shift, okay? So that's that. Now, let's just say that you go through these three motions and you're like, hey, they didn't hurt. Still could be a disc problem. Let's go explore other motions. Let's fully rule out motions of the spine to see if they can recreate your symptoms. So go ahead, stand on up, bend straight forward. See what that feels like. Is it painful or is it not? Then bend forward to the right. Then bend forward to the left. Then side bend straight to the right. Then side bend straight to the left. For most people watching this, it will be painful, which again points to it being a disc issue, and we could head back up here to what kind and go through that. But if it's pain-free, if you're telling me, you know what, Charlie, I thought I had a disc problem. I have pain across my back, I have pain in my butt and the back of my thigh. It seems like the location matches, but I can go through all these motions and they don't bother me. Well, are you sure it's a problem with the structure of the body, with the disc, or with the joints? Probably not, because you should stress something out with these motions. So could it be due to a sensitive central nervous system, the brain? We'll talk about that in a little bit. All right, so let's backtrack. Where were we? Location was here. But we also talked about how facet and disc problems could also present as this. So if you don't have symptoms that cross the midline, it stays on one side of the spine and goes into the butt and or the back of the thigh, then disc and facet joint issues are kind of a toss-up. It could be either, and this kind of makes it a little bit tricky. SI joint nerve problems are pretty much gone, not that. So go through the same self-movement test. Go through these back bends. Straight back bend, rotate to the left, bend straight back, rotate first all the way to the right, bend straight back, and one of three things are going to happen. If you experience pain during the motion, let me be clear. If you're going through one of these motions and as you start to bend backwards, you feel a little bit of a catch, and then maybe you feel some pain at the end range. And or as you come up from the back bend and you return to standing, you feel a little bit of a catch. And that is pain during motion, and that is most consistent with a disc problem. But let's just say you have pain only at the end range of motion. So you stand on up, you bend backwards, and you say, ouch, I feel it when I get to the very end of the back bend. Well, that could still be a disc problem, or it could be a joint problem. So what I want you to do is another test. So I want you to perform what we call a repeated movement exam or test. And so if tolerated, if not, that's okay, but if and as tolerated, please repeat the yucky back bend. If you had multiple yuckies, just pick one. This is the simplest one. But repeat the yucky back bend 10 times for me. And when you do that, one of three things is going to happen. Pain may stay the same or worsen the more you do it. So you feel pain at end range, you say, ouch, then you let it off and you're good. Ouch, then you're good. Ouch, then you're good. It just doesn't get any better and or it gets worse the more you do it. Then this shifts the probability a bit towards it being more of a joint problem. All right, and joint issue, you can see here's a facet joint between the vertebrae or bones in the spine. And there are certain things based off this article and resource right here that are associated with joint problems. Age greater than 50, so these joint problems generally occur in folks who are a little bit older versus disc problems a little bit younger. There is no pain when getting up from sitting, as I talked about in the disc portion of things earlier. Generally, disc issues do cause pain when transitioning. It causes stiffness when going from a sitting to a standing position. Coughing and sneezing with disc problems, as I'll reiterate here in a moment, generally increases pain with disc issues, but it generally doesn't with a disc problem. Pain is often better while walking or sitting. Doesn't really help you. This is often the most painful type of back bend, rotating and extending to the side of the joint, which is most aggravated. Okay? Now, that's the path we follow if pain stays the same or worsens the more you do it. But pain may lessen the more you do it, or it may move in location, or you might not be sure. Let's go through those types of scenarios. So if pain lessens the more you do it or moves in location, meaning as you back bend, you felt the pain. Then you did it, you're like, huh, the more I do it, it's a little bit better. And or I felt pain in my thigh, the back of my right thigh, let's just say, or my left thigh. But the more I do it, now it's in my butt. Or the more I do it, now it's not in my butt, but it's in my back. Or now maybe completely gone. This really shifts the probability in the favor of a disc problem, because likely what you're experiencing, if you're noticing a reduction of symptoms with these repeated back bends, and or if you notice that the symptoms are moving, so it starts here, it goes to here, or it goes to here, or it completely goes away, is what we call centralization, and this is highly diagnostic of a disc problem. All right, so again, what type of disc herniation? Probably a disc protrusion of mild to moderate in form or nature, and age greater than 50, central back pain, trouble straightening up, worse in the morning, often worse with bending, sitting, driving, better with walking, standing, roller coaster, maybe a shift. All right, review that if I went through it too fast, but we already reviewed that, okay? Now let's just say you're not sure. You go through these motions, you went through this repeated exam, you're like, you know what, I can't tell what happened. Maybe it got worse, maybe it got better, maybe one time hurt, maybe the next time it didn't. It's just kind of funky. Here's what I would ask you do. A little bit of a ninja trick here to help you figure out what's going on. If you're not so sure, I want you to do your yucky back bend, again, just one time. Get an idea for how far you move and what it feels like, the amount of symptoms you experience while you're doing it. Then what I want you to do is I want you to do the opposite of that, which is yucky. I want you to go ahead and, if tolerated, and only if tolerated, can you hold a seated forward bend for roughly 60 seconds? So you can pause the video and come back to it. And then I want you to immediately get on up and retest your back bend one time. If your back bend is now all of a sudden jammed, limited, less motion, more painful, then this is highly diagnostic of and or indicative of a disc problem. Because when you are bent forward, you are relieving pressure on the joints, but you're potentially increasing pressure on the disc. So if you spend a lot of time bending forward, it's possible you could be deforming the soft tissue in the spine such that then when you go to bend backwards, oh, all of a sudden your motion is blocked. You see a rapid change or deterioration in this case of your ability to bend backwards. If you have no change in motion or pain, bending forward shouldn't affect the joints at all. In fact, it should make it feel better. Then this points to more of a facet joint or degenerative joint arthritic type of issue affecting those joints in the lower spine. Okay, so if that's confusing at all, go back and watch it. Final thing, let's just say you went through these motions and it was pain-free. Well, maybe you haven't stressed out the joints enough. Maybe you haven't stressed out the disc enough, as we talked about earlier. So go through the rest of the movement exam, bend forward with the spine and standing, forward to the right, forward to the left, side bend to the right, side bend to the left, and one of two things are going to happen. Either it's going to be painful, in which case we say most likely disc, or it's going to be pain-free, in which case we say, are we sure it's a disc or a joint problem? Probably not. Maybe more brain. So, where were we? We talked about the most common things there, what it isn't, all that good stuff, big, ugly, scary stuff. Now we are here, all right? So now we're in this area, brain. So we've ruled out cancer, fractures, infections, peripheral arterial disease, disc problems, facet joint problems, all these problems, whereby we now can feel confident the pain we're experiencing is not due to damage within the body, but potentially sensitivity of the brain, whereby the pain you're experiencing is not due to physical damage, again, but due to danger, perceived danger. Now, this can cause, again, very real physical pain or symptoms anywhere in the body, so symptoms caused by a sensitive central nervous system can mimic any of these things. I shared with you Pearl as an example. She was diagnosed with spinal stenosis, and does she have it? Yes, but it wasn't the cause of her symptoms. Her mind was making a bit of a mistake, all right, and causing very real symptoms that she was associating with the spinal stenosis, but of course, treating the spinal stenosis wasn't working, okay? Now, how do we know if this is really the problem or not? Right? So this is not woo-woo, this is based off neuroscience, and how we do it is we really lock you in on the logic and help you create what we call your evidence list. So we just look at the facts here. We don't go based off of what you think or you feel or if you believe this is something that can happen. Just look at this and ask yourself if it makes sense. So first things first, I have 13 questions here. I want you to ask yourself these questions and just simply answer yes or no. All right, so first one, are you unsure as to why your pain began? Meaning there is no clear injury or cause for why you hurt. I don't know about you, but generally when I damage something in my body, I'm pretty aware of it. If I hit my finger with a hammer, I know that I hit my finger with a hammer. Is your pain chronic? Most things in the body, including disc herniations, will heal and reabsorb within a 6-month time frame. But why is it that symptoms could last beyond that? 6 months, 9 months, 6 years. Is it possible your symptoms are more of the brain than they are of the body at this point? Because, well, the body should have healed in a reasonable amount of time in this time frame. Did your pain begin during and or around a time of fight or flight? This could be good or bad stress, career changes, birth, death, divorce, financial stuff, any of that stuff. If so, again, this is an indicator of maybe the mind has something to do with it. Is your pain inconsistent? Some good days, bad days, where you're maybe not sure as to how you could explain that. Does stress trigger your pain? Do you experience relief of your pain with distraction? Maybe you go on vacation, you're like, I felt great for a week, and then you come back to your boss and symptoms flare up again. Do you have pain or symptoms or problems in other parts of your body? So commonly we see that because the brain can create very real physical problems anywhere else in the body, we see that, yeah, maybe you've got some back and butt stuff, but maybe you've got shoulder stuff or migraines or digestive issues. So do you have symptoms elsewhere? Does your pain shift, spread, or move around and you don't know why? Charlie, I had it in my right butt cheek today, but then it kind of went away and now it's in my left butt cheek. If so, then this is a sign that symptoms might not be due to a problem in your body, disc problem, joint problem, etc. Do you experience a delayed onset of pain? Charlie, I did physical therapy, and while I was doing it, I felt fine, but later I couldn't walk. I went for a run and I felt good, but later the next day I had a hard time functioning. So delayed onset of pain is a sign of things centrally driven. Have you been given many or no clear diagnoses, in which case people aren't really clear as to what's going on, and they can't agree upon it. So is there something actually going on physically? Maybe your MRI even looks clean. Very common as well. Do you identify yourself as having a high-pressure, perfectionist, people-pleaser, type A, good student, get it done, Charlie, just tell me the exercise and I'll do it 10 times a day if I need to type of personality? If so, that means you live in a more elevated state. Your nervous system is probably a little bit ramped up compared to some other folks. It's not a good or a bad thing. You're probably very good as it relates to your career, relationships. You're probably a pretty good mom or dad or cousin or whatever, but that could keep you stuck in pain. Is it hard to identify specific yucky motions? So maybe you went through these motions today and you're like, you know what? That one hurt, but then it didn't hurt. And, you know, I go to the doctor and sometimes this hurts and sometimes it doesn't hurt. Or maybe you just notice for yourself that things aren't consistent. They kind of fluctuate. I call this an unclear movement-pain relationship. Maybe there is no relationship, and the lack of a clear movement-pain relationship is the pattern. The absence of the pattern is sometimes the pattern, all right? And has there been a lack of response to physical treatment, in which case that might make sense. If it's a physical problem, it should respond to physical treatment. But why is it not? And so if you answered yes to 7 or more of these 13 questions, then this shifts the probability in favor of being more of a central nervous system sensitivity issue instead of a body issue. If you answered yes to 6 or less of these, then it is likely caused by something structurally within the body, but we would need to do further evaluation. All right, so there you have it, the complete diagnostic process that I use to figure out the most likely source of symptoms for people who present with back and buttock pain and symptoms above the level of the knee on one or both sides. These are the most likely causes. We went through them today, but maybe you have some other funky symptoms. If you want the complete diagnostic guide, even more expanded than this, go ahead and check out my Better Than an MRI DIY diagnostic guide. You can download that above for free. Now, if you went through this and this was helpful in any way, just let me know, like, what is the most likely source of your symptoms? Just comment below. Thanks.